Good afternoon, everyone, and welcome to today's Public Health Ontario Microbiology Rounds presentation on syphilis, controlling an old disease with modern technologies. My name is Dr. Vanessa Tran. I am a clinical microbiologist at Public Health Ontario, and I have the absolute pleasure today of moderating today's session. Before we begin, I just wanted to mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentations, so please use the Q&A pod if you have any questions during the session. Discussion and question period will follow the presentation. And if you require any CME credits, or if at any point during the session you experience technical issues, please don't hesitate to email capacitybuilding@oahpp.ca. I would like to state that as the moderator of this session, I do have some conflicts of interest to disclose. I am on the board of the Canadian College of Microbiologists and Canadian Association for Clinical Microbiology Infectious Diseases. I'm also a co-investigator or collaborator on some grants that are funded by CIHR, CERN, PHAC, and Gilead. It is now my pleasure to introduce the speaker for today's presentation, Dr. Raymond Sang. Dr. Sang is the Laboratory Chief for Syphilis Diagnostic and Vaccine Preventable Bacterial Diseases at the Public Health Agency of Canada's National Microbiology Laboratory Branch. He has extensive experience in clinical microbiology, especially bacterial diseases, immune response to bacterial infection, laboratory diagnostic methods, and genomic epidemiology. He has done amazing work, and his work on vaccine preventable bacterial diseases supports Canada's immunization program ACTIVE, or IMPACT, and the National Advisory Committee on Immunization, or NACI, on meningococcal disease, Haemophilus influenzae, and pertussis. He is currently a member of the Public Health Agency of Canada's Syphilis Outbreak Investigation Coordinating Committee and co-chair of the Syphilis Working Group for the Canadian Public Health Laboratory Network. He works with international partners, including the US CDC, UK Health Security Agency, and Francis Pasteur Institute, and as well as the Pan American Health Organization, or PHO, on syphilis and vaccine preventable bacterial diseases issues. And because he isn't busy enough, he also currently serves as an editor for the Canadian Journal of Microbiology. Welcome, Raymond, and very much look forward to your talk today.
So thank you very much, Vanessa, for your kind introduction. Before I begin, I also like to make some disclosure. I do not have any conflict of interest to declare. And I also want to stress that views expressed in these presentations are my own and they do not reflect the view of the agency or the National Microbiology Laboratory. This slides will show the disclaimer from Public Health Ontario. And the learning objectives of this session is to explain laboratory diagnostic methods for syphilis, describe FACT's 5-year action plan on STBBI with emphasis on syphilis, and National Microbiology's response to the current increase in infection rates. And lastly is to recognize newer diagnostic methods and appreciate the challenges in syphilis diagnosis. Because of the wide background of the audience, what I would like to do is to describe to you briefly the causative agent for syphilis and its characteristic, and to show you this is an old disease for our younger audience. I'd like to spend a few slides on the origin or history of syphilis infection. Then I will introduce laboratory diagnosis of syphilis and use surveillance case definition to highlight some laboratory diagnostic method. Then I will introduce recent epidemiology of infectious syphilis in Canada, which then will bring us to the Pan-Canadian framework on STBBI, as well as Government of Canada's 5-year action plan on STBBI. So as a laboratory branch, then I would discuss about the newer diagnostic methods. And finally, to sum up, I will describe some challenges in the control of syphilis infection. So syphilis is caused by the bacterium called Treponema pallidum, subspecies pallidum. And there are 2 other subspecies, endemicum that cause non-venereal syphilis or BGL, and the subspecies pertannua, which causes yaws. And Treponema caratum causes pinta. And this group of treponema organisms, they cause either syphilis or non-venereal treponema disease. Only syphilis is transmitted sexually and also vertically from infected mothers to baby, as well as via blood. Non-venereal treponema diseases are usually transmitted by non-sexual direct contact. PGL or non-endemic syphilis occurs in the dry region of Eastern Mediterranean and Sahara West Africa. Yours occur in the humid equatorial countries, while Pinter has been reported from Mexico, Central America, and South America. This slide shows a map of the globe, and the part highlighted in purple on the left-hand side shows where Pinter has been reported as of 2012. The part of the globe or map that is highlighted in green shows where PGL has been reported, and the part that is colored in blue shows the equatorial countries where yours have been reported. Some characteristic of the causing agent. This is a spiral organisms, which has a unique motility, and the motility is caused by rotation of the flagella in the periplasm, causing the entire cell body of the bacteria to rotate and undulate. It has been described as an invasive bacteria, as well as able to evade immune response, and therefore it has been called a staph pathogen. Also, it is non-culturable and antigenically very similar among all the pathogenic treponemas. So to talk about the brief origin of syphilis, there is a couple of hypotheses. The first hypothesis is called the pre-Columbian hypothesis. It suggests that Pinter exists in Africa, Asia around 15,000 BC. And the causative of yours then arose from the causative agent of Pinter around 10,000 BC and spread around the world, except New World. Then the agent of endemic syphilis arose from yours around 7,000 BC, and around 3000 BC, the causative agent of venereal syphilis emerged, and Columbus brought it to the New World. The other theory is the Columbian hypothesis, which suggests Christopher Columbus, seaman, brought the disease to Europe after discovery of the New World. And this timing correlates with the first reported outbreak in Europe during the War of Naples in 1495. Finally, the Unitarian hypothesis suggests that both syphilis and non-venereal treponema diseases are variants of the same infection, and the clinical differences of these diseases are the result of geography, climate condition, cultural differences. Or in other words, the original treponema bacteria adapted to different environment and host customs to become agents causing syphilis, PGL, yours, or Pinter. For those who are interested to find out more about the history or origin of syphilis, I have provided some references at the bottom of the slide. So moving on to laboratory diagnosis of syphilis, there are two ways to do that. One is by direct detection of the bacteria or its nucleic acid, and the other is by serology, measuring the antibody response to syphilis infection. For direct detection, nucleic acid amplification method is one, and the common nucleic acid amplification test is PCR. And another method is using immunohistochemistry to detect the organisms using specific antiserum and enzyme reactions to detect the organism in histopathology slides, specimens. Also, we can use specialized stain like silver staining and microscopy to detect the organism in histopathology specimens. Also, by directly using microscopy to observe the microorganisms using dark field or phase contrast microscope. These specialized microscopes are required because the organism is very slender in shape and is not visible under light microscopy, even at a 1000 magnification. Another method to detect the bacteria is using direct fluorescent antibody test for Treponema pallidum, or so-called the DFA-TP. And finally, the rapid infectivity test, which is exposing clinical material or infecting clinical material to the rapids and look for the infection to establish. But this method is basically obsolete for clinical purpose. The other category of diagnostic method is serology, which detect antibody either to the Treponema antigen or non-Treponema antigens, and hence they are divided into so-called Treponema tests or non-Treponema tests. Example of Treponema tests include enzyme immunoassay, chemoluminescent immunoassay, Treponema pallidum particle agglutination test, the fluorescent Treponema antibody test, which detects antibody in contrast to the DFA-TP, which detects the bacteria. And finally, the syphilis INNO-LIA. LIA stands for line immunoassay. It's sort of like a Western blot where antigens are immobilized on a solid matrix, exposed to serum, and then the reaction is detected by some reporter molecules that gives out a signal or color change. Examples of non-Treponema tests include RPR and VDRL. Characteristics of serological tests include Treponema test positivity may persist for a very long time. And non-Treponema tests, the titers may decrease with treatment, and therefore following the titer in non-Treponema tests can be used to monitor response to treatment. A positive Treponema test alone cannot be used to diagnose an active syphilis infection. A positive result in the Treponema test is required to confirm a true positive non-Treponema test result, such as an RPR or VDRL result. In the absence of other information, a positive result in both the Treponema and non-Treponema tests alone may still indicate a treated past infection, especially if in the presence of low non-Treponema test titers, such as a low RPR or low VDRL titer. Also, early in an infection, serological response may be negative. But also very important to note is both syphilis and non-venereal Treponema infections can induce the same positive serological response. So, I will turn to very briefly case definitions and use it to illustrate some important points about laboratory diagnosis. A surveillance case definition is a set of uniform criteria used to define a disease for public health surveillance. It's not intended to be used by healthcare providers for making a clinical diagnosis. And in the US CDC, National Notifiable Disease Surveillance Systems, a number of case definitions have been described for different stages of syphilis. And if you're interested, a link to the website is provided at the bottom of the slide. In the US CDC case definition for confirmed primary syphilis case, it defines it as a case that meets the clinical description of primary syphilis, which I won't go into detail here, but more importantly, in the presence of confirmatory laboratory criteria. So what is the confirmatory laboratory criteria? It is either by demonstration by dark field microscopy in the clinical specimens that was not obtained from the oropharynx and is not potentially contaminated by stool, or demonstration by nucleic acid amplification test of DNA of Treponema pallidum or equivalent molecular methods in any clinical specimens. The US CDC case definition for a probable primary syphilis case is it meets the clinical description of primary syphilis and in the presence of supportive laboratory criteria, which are either a reactive non-Treponema serological test or a reactive Treponema serological test. The important message I want to bring up here is the use of direct detection methods such as a PCR. And because in the previous slides also shows the challenge, even in presence of positive results in both treponema and non-treponema tests, especially with low titer RPR and VDRL, it may not indicate an active primary syphilis infection. I also include on this slide a website that links to the Canadian case definition for syphilis. I think it is important for me to mention that the Canadian case definition for syphilis is currently under review, and so new case definitions will probably be available soon. And from my discussions with the US CDC about case definition for syphilis, I heard that they are also talking about re-examining their case definition or updating their case definition. So I'm going to use the next few slides to describe the recent epidemiology of infectious syphilis in Canada. The data has been beautifully assembled by my colleagues in the STBBI Surveillance Division in Ottawa, and the data have been published in the Canadian Communicable Disease Report last year. So this slide shows a map of Canada. On the right-hand side, you can see a bar with different intensity of the purple color. The deeper the color, the more increase in the infectious syphilis rates. And if you can see, it's very clear in this figure that central Canada, or I beg your pardon, is the Western Canada and the Northwest Territories have very great increases in the infectious syphilis rates from 2017 to 2021, covering over 400% increase in Alberta and Manitoba, and over 1,000% increase in Saskatchewan and Northwest Territories. And the infectious syphilis cases in Canada involve both gender. I would like you to focus on the vertical axis on the right-hand side, which shows rate of infectious syphilis per 100,000 population. And the three lines in the middle of the graph shows infectious syphilis rates for females at the bottom in colored red, and the infectious syphilis rates for male is color blue on the top. And as you can see, increases in infectious syphilis rates happen in both gender. But if you look at the increase in the infectious syphilis rates in females, it rose from about less than 5% in 2017 to about 20% in 2021, which is more so than the rate increase in males. Therefore, this involvement of females lead to unprecedented increase in the number of congenital syphilis cases in Canada. So there were 96 confirmed early congenital syphilis cases in 2021, compared to only 7 in 2017. This slide is also provided by my colleagues at the STBBI Surveillance Division in Ottawa. Beautifully shows the correlation between infectious syphilis rates in female of childbearing age and the number of congenital syphilis cases reported. As the case rose, denoted by the solid line, number of cases of congenital syphilis increases, as shown by the bar. So I want to use just a couple of slides to show the global epidemiology, so that the increase in syphilis is just not in Canada, but also happened elsewhere. So recently, in July 2023, WHO released the Global Epidemiology Report on STI. They estimated more than 1 million STIs acquired every day worldwide. The majority are asymptomatic. And also 1 million pregnant women were estimated to be infected with syphilis in 2016, resulting in over 350,000 adverse birth outcomes. So World Health Organizations has then established and published a global health sector strategies on respectively HIV, viral hepatitis, and sexually transmitted infections for the period 2022 to 2023. And in that report, the goal and target for syphilis include lower the number of new cases of syphilis among people 15 to 49 years old to 0.7 million per year by 2030, I beg your pardon. Another goal is lower congenital syphilis cases less than 50 per 100,000 live births per year by 2030. Canada endorsed the PHO Global Health Sector Strategy on STBBI, the United Nations Sustainable Development Goal, and the Joint United Nations Program on HIV and AIDS. These programs have a common goal of elimination of STBBI as a public health concern by 2030. To achieve this, the Public Health Agency of Canada has developed a pan-Canadian framework on STBBI, which has been endorsed by federal, provincial, and territorial ministers of health. The goals of the pan-Canadian framework on STBBI include reduce the incidence of STBBI in Canada, improve access to testing, treatment, and ongoing care and support, reduce stigma and discrimination that create vulnerabilities to STBBI. This diagram shows the 5 core pillars of this pan-Canadian framework on STBBI. And you can see on the outer on top is testing, then you have initiation of care and treatment, ongoing care and support, and prevention. And in the middle of this diagram is the 5th pillar, which is the creating enabling environment that will allow the 4 other pillars to be implemented more successfully. So the Government of Canada's 5-year action plan on STBBI include the following. And it supports it supports the pan-Canadian framework on STBBI, which is to reduce incidence of STBBI in Canada, improve access to testing, treatment, care, and support, and reduce the stigma and discrimination that creates vulnerabilities to STBBI. So if people are interested in reading about this 5-year action plan, it's described in the reference shown on the bottom of the slide. So this slide shows 10 different federal departments are involved in this 5-year action plan. And it's led by Public Health Agency of Canada, involved CIHR, Correctional Service of Canada, Department of Justice, Department of National Defense, Department of Women and Gender Equality, Health Canada, Immigration, Refugees and Citizenship of Canada, Indigenous Services of Canada, and LGBTQ2 Secretary of the Privy Council Office. So as a laboratory branch, NMLB's focus on delivering this Government of Canada 5-year action plan focused quite a bit on newer diagnostic method. And this is to improve access to testing. And in this area, NML is working towards evaluating syphilis point-of-care tests by evaluating the commercial point-of-care test kits in the laboratory setting, as well as doing field evaluation, which is done with research ethics board approval locally and at the federal level, as well as done under the approval of Health Canada Medical Device Directorate's Investigational Testing Authority. NML is also working with provincial and territorial public health partners to develop guidelines for the laboratory diagnosis of syphilis, including the use of point-of-care test kits. And the next couple of slides is to describe to you what is the landscape of syphilis point-of-care test kits. Currently available syphilis point-of-care test kits detect antibodies to the causative agent. one category of product detects antibodies to just Treponema pallidum. Another category is multiplex detect antibodies to both Treponema pallidum as well as HIV-1 and 2. And those detect antibodies to Treponema pallidum can be further divided into those that detect antibodies to Treponema antigen and those that detect antibodies to both Treponema and non-Treponema antigen. And in the WHO document, diagnostic landscape for STI, which was released earlier this year, it described a total of 19 rapid diagnostic tests for syphilis, which most of them have obtained either the European Union approval on in vitro diagnostic tests or FDA approval or WHO pre-qualification approval. And of these 19 point-of-care test kits that described by WHO, 11 are for detection of syphilis infection, 7 are for detection of HIV and syphilis infection, and only 3 detects and only 1 detect antibody syphilis infection based on measurement of antibodies to both Treponema and non-Treponema antigens. In Canada, as of end of July 2023, this year, Health Canada has only approved the use of 1 point-of-care test that detects HIV and syphilis infection, and it's meant to be used by a healthcare professional. And this test is the INSTIT multiplex HIV-1, HIV-2, and syphilis antibody test. This is a single-use rapid test that gives results in 60 seconds for detection of IgG and IgM antibodies for both HIV and Treponema pallidum in whole blood, serum, or plasma. And the result is read visually and does not require any specialized reader. I want to add that this particular test only measures antibodies to the Treponema antigen. So you may ask, what is the ideal characteristics of a point-of-care test kit? Now, this criteria, a sure criteria introduced by WHO, does not just apply to the syphilis point-of-care test kit. It applies to any point-of-care test kit. ASSURE stands for affordable, sensitive, specific, user-friendly, rapid and robust, equipment-free, and deliverables to end users, which means it does not require cold chain storage or cold chain delivery systems. As of 2023, no syphilis point-of-care test kit has met all these criteria. So other National Microbiology Laboratory Branch contribution towards the 5-year action plan on STBBI include developing innovative diagnostic testing, and these include working, for example, with our partners. In this case, NMLB is working with Dr. Venkata Duri of PHO lab to mine the genome of Treponema pallidum to identify newer diagnostic markers and or potential vaccine candidates. And we also have collaboration with the National Research Council of Canada to develop rapid antigen detection tests. NRC has a very wide network of industrial partners through its IRAP program. And also NRC has its own medical device research center. NMLB, Dr. John Kim of NML has also done a lot of work on dry blood spot. And then other activities of NML include, for example, NML is working with Dr. Tom Brockman of PHO lab and other NMLB scientists and provincial public health laboratory partners to develop metagenomic methods and pipelines to provide molecular typing and monitoring antimicrobial resistance. Last but not least, Dr. Paul Sandstrom and his STBBI team at NMLB is also doing outreach and engagement activities with indigenous populations to enable the environment for testing, prevention, treatment and care, as well as ongoing care and support. Now, I think the outreach activities that Dr. Sandstrom and his team provide is very important, as described in the Pan-Canadian STBBI framework. The central pillar is to enable environment, is to create an enable environment. And this is what Dr. Sandstrom and his team has been working very hard over the years to do that with our indigenous population, with our population in the north, which are vulnerable to STBBI. Challenges in the control of syphilis. And there are many of them, and I'm just listing a few here. The disease syphilis has been described as a great imitator. So in other words, the clinical presentations can be sometimes obscure, and sometimes physicians may not think of syphilis. In fact, it may be syphilis. So, and another case is another reasons or challenge in the control of syphilis is there's a lack of vaccine for prevention. Also, there's a lack of rapid diagnostic tools that can identify infection and offer treatment at the same time. And right now, diagnostic tests are usually centralized. They are sent to the centralized laboratory, and then results are only obtained next day. And then it would take time for the ordering physicians to receive the results. And by that time, you would require the patient to come back and receive treatment or any follow-up. Last but not least is also the limited choice of antibiotics for treatment. Despite all the, here in this slides, I would like to describe challenges and some potential solutions we are working on for implementation of syphilis point-of-care test kits. Point-of-care test kit can be regarded as a decentralized testing because it can be carried out in the community in various parts of the society. And so the challenge is, once the test is done, how do you capture these results for surveillance purpose in order to keep track the disease epidemiology as well as any success in the implementation of any program. So NMLB is working with the Canadian Public Health Laboratory Network and partners to discuss a system to capture the point-of-care test kit results once this is rolled out. NMLB is preparing proficiency program for control of test kits, as well as control, as well as to ensure quality performance by operators performing the point-of-care test kits. Another challenge is if point-of-care test kit is deployed in the non-clinical setting, how would treatment be administered, especially in view of the current guideline for treatment of primary and secondary syphilis, which is long-acting penicillin given in injection. Maybe a little bit of hope can be found in the next bullet point, which is that currently oral antibiotic doxycycline has been proposed as a prophylactic agent for bacterial STI. And you can, at the bottom of the slide, I have provided a recent publication in Clinical Infectious Disease that describe the use of doxycycline for prophylaxis. So the doxycycline prophylactic use can be pre-exposure or post-exposure. Currently, multi-center clinical trials on the use of doxycycline prophylaxis are happening, including some in Canada. FACT is also following the results and examining the pros and cons for this approach in the control of bacterial STI, including syphilis. And this part is led by our colleague in the STBBI Surveillance Division in Ottawa. Now, whether doxycycline can be used for treatment of early syphilis when cases are identified by point-of-care test kits remains to be determined. So in conclusion, the increase in syphilis infection is unprecedented, involving both genders and leading to a record number of congenital syphilis cases detected in Canada. It seems the traditional way of laboratory diagnosis may not be adequate to identify, treat, and control the current level of transmission of syphilis. And that leads to the need for newer technologies And these newer technologies may include point-of-care test kits for detection of antibodies that can identify infectious syphilis, and point-of-care test kits for detection of antigens, similar to direct detection method for laboratory diagnosis of syphilis. And also preventative vaccines probably will help to control the disease. And newer treatment options that does not require antibiotics given by injections can certainly help, especially when the disease are diagnosed and the treatment is required in the outdoor communities or in the street level. So finally, I would finish up by acknowledgement. I personally thank many of my colleagues within NML and as well as within FAC over the years, especially staff that work with me in the laboratory. I also thank the provincial and territorial public health laboratories and officials for their contribution and collaborations over the years on this file. And I also thank Venkata, Tom, and Menisa of PHO Lab for their collaboration on the syphilis project. And I also thank my many international colleagues for sharing information and stimulating discussions. So with that, I thank you, and I would turn the time over to moderator Ben.
Thank you. Thank you so much, Raymond. That was such a clear and informative presentation. We already have a number of questions in the Q&A pod. Please keep them coming. I will take this opportunity, since you did bring up DoxyPEP, to plug a PHO rounds for next Thursday, September 28th, on doxycycline and use for PEP and syphilis. So if you have not seen that invitation, please head over to our website. And maybe we can pop that link in now in case you're interested and you want to register. So now we'll move on to the Q&A segment of this event to address some of the questions from our audience. So just a quick note, please continue to enter your questions into the Q&A pod if you have not had an opportunity to do so. We have a number of questions. I'm going to try to lump them together by category because they range from epi to lab testing and point of care testing. So first, I'm gonna ask some of the epidemiological questions, and this is related to the a very high increase we've seen in Alberta, Saskatchewan, and the Northwest Territories. Wondering if you can comment on why these increases have been so dramatic in those jurisdictions, and along those lines, with respect to congenital cases. If these could have been related to the decrease in access to prenatal casing during the COVID pandemic.
Okay, thank you for the questions. These are interesting and challenging questions. And I guess the increase in the infectious syphilis in the past few years is really a very complicated problem. And it's multifactorial. It's probably not related to a single factor. And I think some of the contributing factors to the return of syphilis in such a huge manner probably related to the society practice. For example, I mean, I've heard from frontline people that the use of mobile apps to connect with people for sexual encounter potentially contribute to a rise in STI infection. And I'm sure all of us have heard of drug overdose, and this relates to substance abuse, and it has been on the rise in the past few years. And the tremendous increase in the Western provinces and Northwest Territories. I don't know whether it will be potentially at least part of the reasons, maybe the population ethnical diversity of these, in different provinces. and especially potentially related to homelessness and certain population we know are more vulnerable to STI infections.
Thanks. That's certainly a very complex issue. And again, just to touch on specifically the congenital cases, I think as you mentioned, at least I can speak in Ontario, the cases of congenital syphilis are in populations that are more vulnerable, such as the unhoused and those who use substances. So certainly the COVID pandemic could have an impact on access to prenatal screening, but I think just in general, these vulnerable populations already don't have good access to prenatal care. So again, they're very complex and multifactorial. Okay, next I'm going to jump to some questions about the case definitions. I think there are some questions related to the anticipated change. I'm not sure if you can comment on what is changing in the national case definitions, and specifically with respect to the congenital syphilis case definitions, whether or not it would include syphilis stillbirth, similar to what is listed in the CDC.
Okay, I don't think I can, because the Canadian revision of the Canadian case definitions have not been finalized. So I don't think I am, I can release too much details, but definitely in the congenital syphilis case definition, syphilis stillbirth will be included. And I think it will be a separate categories. So that I think I can share. But I don't think further details. I think it would be better to wait because there are not many approval levels that have to go through, both within the government, the federal government, as well as with our provincial partners. Thank you.
It's completely understandable. Do you perhaps have an idea of when the new case definition is anticipated to be released?
The revised congenital syphilis case definitions are close to final approval process internally within FACT, and it will be shared with our partners. And so I think that I would envision that this will become available over the next few months, or even maybe shorter.
That's wonderful to hear. Okay, now we're going to jump to testing. I think there's a lot of questions about testing and specifically around the point of care test. But before we get to the point of care test, there's a question about how readily available the NAT testing is, and would it be more sensitive than other direct detection methods?
Oh, okay. So I think many provinces have already adopted nucleic acid amplification tests. And NML either provide the testing, or we are very supportive to help provinces to establish their own test. Of all the direct detection method, I would probably say nucleic acid amplification test is probably the more sensitive than the others.
And maybe add in a little bit of the Ontario landscape. Currently at PHO, we do not have syphilis NAT or syphilis PCR for direct testing, but we are actively working on it. So hopefully it will be implemented in the very near future. Okay, I think there's a ton of interest about point of care testing. I'm going to try to lump the questions together as much as possible. So a question about the INSTI point of care test that is approved by Health Canada. So you mentioned it's the only one that's currently approved. Can you speak to any of the limitations around its use for diagnosing syphilis and HIV?
I am not experienced with the HIV file, and because the HIV file is under our HIV division. However, I can speak on the syphilis component of this multiplex test. Like I explained in the presentation, it detects only antibodies to the treponema antigen. And you can envision presence of antibodies to the treponema antigens cannot differentiate active from past syphilis. But nevertheless, having said that, I think if the test can be used together with clinical observations in the presence of symptoms or ulcers, and then likely the test will be useful to speed up the initiation of antibiotics.
Thanks, Raymond. I think you also had another question, which was whether or not they can be used to diagnose new infections in individuals who've had a history of syphilis infection that were treated. So again, as you mentioned, really in terms of the test performance, no, but it has to be used in combination with the previous clinical history, treatment history, in order to be able to differentiate like an old versus new infection. I think there's a lot of interest by public health units and healthcare providers here about the availability of point of care testing. I don't know if you can speak to that specifically, even nationally, and maybe I can have a little bit of input provincially in terms of the availability.
Right. I think that they understandably, when I interact with different provincial partners and territorial partners, they always ask about point of care test kits, understandably. And I think that not just in the public health sector, but in the industry sector, there's a lot of interest in developing point of care test kits. I can tell you that a number of manufacturers are making newer syphilis point of care test kits that can detect antibodies to treponema and non-treponema antigens. And some claim to have better sensitivities than the first generation of point of care test kits. And we are working actively with our partners to perform the evaluation as well as to do clinical trial of these newer products. I think one of the important things of doing clinical trial and gather information is not just for approval of the test by Health Canada, but as well as for us to develop some guidelines on how to use these tests. Because I mean, even if you can detect antibodies to both treponema and non-treponema antigens, as I have said before, I mean, when you have a low titer non-treponema antibody results, even in the presence of positive treponema test result, it may not indicate a active infectious syphilis. It may be already treated past syphilis. And then the challenge of using these kind of point of care test kits is once it's decentralized into the community level, then a lot will rely on the accuracy of the test. But definitely, I think that FAC is aware of this intense interest in this file, and definitely we're working very hard to, to meet this demand.
Thank you, Raymond. And I will reiterate or add to that also at the provincial level, there's a lot of interest and discussions around how point of care testing for syphilis can be used. And just to follow up on some of the questions here around follow-up and reporting the point of care tests by healthcare professionals. So currently there are guidelines under review. Certainly if you get a positive point of care test, I would encourage you to do follow-up laboratory testing prior to having those specific guidelines being established for Ontario. And in terms of reporting, I think it's best to separate the actual test as well as the duty to report for the healthcare professional. So if there is a high suspicion of a disease, it should be reported for adequate follow-up. There's a specific question here, Raymond, about I think it's one of the second generation point of care tests. It's the ChemBio DDP syphilis screen and confirm point of care that's being used in the STAR study in Nunavut. Yes. And individuals wondering whether or not this one is under approval review by Health Canada.
Now again, this as far as I know, the manufacturer has not filed application to Health Canada for approval. In fact, that from discussions with the manufacturers, earlier this year, they are in fact focusing on improving the current DPP screen and confirm syphilis point of care test kits, rather than trying to rush to apply for approval using the current product. Now, of course, the complications here is, I believe, and this is known information that you can easily access from the internet. The company has been bought by another company in Europe. Now, whether that will complicate things or not, or that will delay their intention to release the newer test or apply for approval, I don't know. But we are in communication with them, and definitely we are very interested to ensure that a usable product is available in Canada.
One last question about your testing, and then we'll move on to maybe vaccines and more about AMR. It's about self-testing with the point of care. So the HIV, there is the HIV point of care test. There is a self-test version. Can you comment on whether there are discussions around a self-test point of care test for syphilis?
Yes, there are discussions on it, and I believe that the bioanalytical that the manufacturer for the multiplex HIV syphilis point of care test kits, they are actually looking into this issue of I don't know whether it's revising the test or making educational document and try to apply for Health Canada approval as a self-test.
Thanks, Raymond. Okay, let's switch gears a bit and talk about prevention and vaccines. So there's a question more about vaccines that prevent STIs, and whether it's for prevention only. And if you can speak to whether or not there's been any progress with respect to a syphilis vaccine in Canada.
In one of my slides in the presentation, I described, or others have described, that the bacteria that cause syphilis is a staph pathogen that is able, and it is not, in other words, it is not unlike many other bacteria. There are not many immunogenic proteins to work with. Despite the challenges, I think many people are working very hard on this file, and some of the well-known researchers, including Dr. Caroline Cameron at the University of Victoria, and she has a long track record on research on syphilis, and I understand she is also actively working on vaccine development. Here at NML, we are working with the National Research Council of Canada, looking at also making potential vaccine for syphilis.
It's very exciting. Okay, this next question, I'm not sure if I'm interpreting it correctly. So if I'm not, please type in the Q&A to correct me. So given the transition in the morbidity pattern of the disease, could you talk about the possibility of transitioning between secondary and tertiary healthcare services to the vulnerable populations? And then a second, I guess, follow-up questions on the development of a multiplex PCR for the diagnosis of syphilis.
Okay, maybe I'll take the second question first because it seems to be easier. Yes, there have been development for multiplexed nucleic acid amplification test, or PCR, for a number more than just syphilis. For example, the Chatham Provincial Laboratory here in Winnipeg, Manitoba, they have recently released to their clinicians in Manitoba a test that can detect a herpes simplex as well as syphilis, and they call it a genital ulcer panel. And I believe that's what they call it, a genital ulcer panel that detects other pathogens or STIs that can cause genital ulcers.
Thanks, Raymond. Okay, so a question about antibiotic resistance. So with the rising cases of syphilis and an increase in the number of individuals who are being repeatedly treated for syphilis, Is there a concern for increased antibiotic resistance?
Definitely, we are very concerned because we don't want to be the last one to be informed by the clinicians. We have a case of penicillin treatment failure in a syphilis case. And so that's why we are working with actually Public Health Ontario Laboratory to develop a genomics method to monitor for AMR because there has been track record of rapid emergence of antibiotic resistance in the, I think, mid-90s. Azithromycin was introduced for treatment for syphilis, and resistant to azithromycin rapidly developed. And by now, 90% of the syphilis infection cases that we have looked at the clinical specimens, genetic tests predict that they are resistant to azithromycin. Similar reports have been just released from the UK, and I'm sure similar results were reported in the US and elsewhere too. So there is a track record of rapid emergence of resistance to antibiotics. But interestingly, I guess for penicillin G has been used for a long, long time, but it still so far it remains sensitive.
Yeah, it's actually amazing to me that it's remained sensitive to penicillin considering its long-standing use. Just a quick question about the general ulcer panel from CADM, the multiplex panel. Do you know if it includes Mpox?
I'm not so sure. I think it may. I think it may. I think that, but again, I mean, I don't want to speak on their behalf, but I'm sure. I think you can easily assess the information by just searching it on the internet or the CADM Provincial Public Health Laboratory website.
Thanks, Raymond. Just going back again, just to, I guess, the congenital syphilis and the discussion around like prenatal testing. There's a question about whether or not there's been discussions or collaborations with the SOGC. And would there be any guidance changes for prenatal testing for syphilis? So for example, currently the recommendation is testing during the first prenatal visit or first trimester, and then follow-up testing if high risk. But whether or not there would be overarching recommendations to change syphilis screening during pregnancy in terms of frequency.
That unfortunately, I'm not aware of that. There may be, but I think that whenever, my suggestion is whenever there is a suspicious or doubt, I think further screening is probably beneficial because those tests are, non-invasive and easy to do and very low cost. And I would definitely encourage clinicians, if there is a doubt, to include the screening at no matter what stage of the pregnancy.
Thanks, Raymond. Okay, I've cleared the Q&A chat pod. Now I'm going to ask one of my questions. I hope that's okay. So what stood out to me was when you mentioned that none of the syphilis point of care tests meets the assured criteria by the WHO. Can you specifically comment on what aspect they're lacking in? Is it price? Is it performance characteristics?
I think I have to say those are very stringent requirement, and I don't think that a test not able to meet all these requirements is not useful. I think we have to be aware of that now. To exactly, I think, for example, I would say some of those tests that even they may have obtained WHO pre-qualification or FDA approval, etc. They may not, for example, most of them don't detect antibodies to infectious syphilis. So, and that's a challenge.
That's a very good point. Okay, we are at time, unfortunately. So we're going to have to wrap up. And as we wrap up today, I would like to thank you again so much, Raymond, for presenting. I would also like to thank everyone who joined us for today's webinar and for the very excellent questions and participations from our audience. You can expect to receive a brief and anonymous PHO micro-round survey for today's session. Please try to complete this to help us improve our programming. And as a reminder to everyone to save the date for topic, so that's the Ontario Public Health Convention, which will be held on March 26th and April 3rd in 2024, and is now accepting abstract submissions for the program. So please check out tophc.ca, so topic.ca for details. Lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to education events, and click on presentations. Thank you everyone again, and have a wonderful day.